There you can see B. Enlarged muscular area nearly obliterates pyloric channel. Pathophysiology is caused by hypertrophy of the muscle of the pyloric sphincter and becomes elongated and narrow. Diagnostic evaluation is projectile vomiting and ultrasound. And if you haven't seen projectile vomiting, look out. That child will lay there after they fed, and out of nowhere, whack comes this hurl of formula, and it hits the wall. I mean, it is really forceful. Therapeutic management is surgery. Prognosis is good after surgery. Could have GERD, wound dehiscence, or pyloric obstruction. Nursing considerations are to give IVs pre-op to avoid dehydration, stomach compression, post-op vomiting, have IVs until able to feed, PO, and start clear liquids and progress to milk. Encourage parents to be involved with this care. You don't want these parents to look at this child and like freak out. They need to be involved with the care as early as possible, and this is healthy for everyone. Intercession. We talked about that before I asked you what it was. It's telescoping or an invagination of one portion of the intestine into the other. It like goes inside of itself. Occasionally a result of intestinal lesions, often cause is unknown. Diagnostic evaluation, you can look at 2414, the box. Therapeutic management of air enema with or without contrast or saline enema. IVs and decompression via NG tube. 80% successful without surgery. Nursing consideration is listen to the parent's description of colicky abdominal pain, although non-surgical treatment treat as if had abdominal surgery. Watch for passage of normal stool. And there's the intercession. It's going right inside of itself. And there's a good video. Put that up in your URL. Malrotation in volvulus. Malrotation is due to an abnormal rotation around the superior mesenteric artery during embryonic development. Volvulus occurs when the intestine is twisted around itself and compromises blood supply to intestines. May cause intestinal perforation, peritonitis, necrosis, and death. This is a serious situation. We can't twist or cut off the blood supply in our bowel system. And there's two good videos for that. Two good informations, rather. Anorectal malformations. Imperforate anus, what is that? That means it doesn't, anus is not patent. Persistent cloaca, cloacal exstrophy. Genitalia may be indefinite, or you can't define it. Diagnostic evaluation, check for patent anus, meconium at an inappropriate orifice, abdominal ultrasound, and management is manual dilatation by the MD, and nurses and parents are taught to do it at home. Depending on the type of malformation, may require surgery or treatment for a long period of time. Nurse will discharge parents with appropriate information to care for the child. Malabsorption syndromes, characterized by chronic diarrhea and malabsorption of nutrients. May result in failure to thrive, digestive defects, absorption defects, or anatomic defects. Celiac disease, aka gluten-induced enteropathy and celiac sprue. 4 characteristics. Steatorrhea, what is it? General malnutrition, abdominal distension, and secondary vitamin deficiencies. Don't know why But one of our moms, she had a set of twins that we were taking care of. And she started to look like someone that was dying of malnutrition. All her hair fell out. She got very, very thin. And she looked like she was starving to death. And by the time she got down to Philadelphia for her diagnosis, they found out she had celiac disease. And she had to go on gluten-free. And she looked wonderful. 6 months after they diagnosed it, she was fine. But when they say malnutrition, oh my goodness. Pathophysiology, gluten causes the inflammation reaction. Diagnostic evaluation manifests with impaired growth, chronic diarrhea, abdominal distension, muscle wasting, hypotonia, and a poor appetite. Blood work is where you get your diagnosis. Therapeutic management, gluten-free diet. Nursing consideration is dietary management of high calories, fruits, vegetables, and no gluten. Short bowel syndrome. Malabsorption disorder results from decreased mucosal surface area, usually as a result of small bowel resection. If a child has NEC, which is necrotizing enterocolitis, or some problems, and they take away a good chunk of the bowel, this child will wind up with short gut syndrome, and they have dumping syndrome. They don't have anything to digest. Everything comes out liquid, and they can't digest. There's no line of bowel for their to take out the water and hold on to the nutrients and all that. They malabsorb. They also have what's called that dumping syndrome. You put it in, and it really causes them a lot of discomfort. Therapeutic management: preserve as much of the intestine as possible, maintain normal growth and development while intestines adapt, stimulate intestinal adaptation and external enteral feedings, minimize complications related to disease process and therapy. Nursing considerations is to minimize nutrition complications during TPN, prepare family for home care, meet emotional needs while hospitalized, and refer to home care to follow up. The child with cardiovascular dysfunction. Now we're going to talk about the heart problems. Fetal circulation structures: the umbilical vein, umbilical arteries, the foramen ovale, the ductus arteriosus, and the ductus venous. Changes at birth. This tells you before the baby was born, and then when they were born, what happens to the fetal circulation then. Pediatric indicators of cardiac dysfunction: poor feeding, tachypnea, tachycardia. What is tachypnea? What's tachycardia? Failure to thrive, poor weight gain, activity intolerance, developmental delays, positive prenatal history, positive family history of cardiac disease. Two types of cardiac defects: congenital, anatomic, resulting in abnormal function, or acquired, disease process, infection, autoimmune responses, environmental factors, or familial tendencies. Chromosomal or genetic, 10 to 12%. Maternal or environmental, 1 to 2%. Maternal drug use, fetal alcohol syndrome, 50% have congestive heart disease, chronic heart disease, congenital heart disease. Maternal illness, rubella in the first 7 weeks of pregnancy, 50% risk of defects, including patent ductus arteriosus and pulmonary branch stenosis. Cytomegalovirus, toxoplasmosis, and other viral illnesses lead to cardiac defects. That's why we tell you, when you're pregnant, don't empty out the kitty litter. The toxoplasmosis. IDMs, infants of diabetic moms, 10% risk of congenital heart disease. VSD, cardiomyopathy. TGA, most common. Multifactorial, 85%. CHD, incidence is 5 to 8 per 1,000 live births. About 2 to 3 of these are symptomatic in the first year of life. Major cause of death in the first year of life after prematurity. Most common anomaly is ventricle septal defect. 28% of kids with CHD have another recognized anomaly, not just a cardiac one. Older classifications of CHD. Acyanotic and cyanotic. It may become cyanotic. It could be that you don't look blue and you're not gasping for breath and you're not losing oxygen. And cyanotic may be pink, may develop congestive heart failure. They're very, very tricky. Third day of life is usually, if they're not with a like tetralogy of Fallot or any of that, if they don't have that, then it could even be 3 days old, 4 days old before something presents itself. Newer classification. Hemodynamic characteristics: increased pulmonary blood flow, decreased pulmonary blood flow, obstruction of blood flow out of the heart, mixed blood flow. Increased pulmonary blood flow defects: abnormal connection between two sides of the heart, either the septum or the great vessels. Increased blood flow volume on the right side of the heart. Increased pulmonary blood flow. Decreased systemic blood flow. So there's 3 ways it'll show itself. Increased pulmonary blood flow defects. Atrial septal defect. Ventricular septal defect, or patent ductus arteriosus. What's that one? Arterial septal defect. Arterial septum. You can see that there's a problem. A hole there. Ventricular septal defect. It goes to the ventricles. It's going out into the lungs and out to the body. Atrioventricular canal defect. There it is there. Patent ductus arteriosus. Obstructive defects: coarctation of the aorta, aortic stenosis, or pulmonic stenosis. Coarctation. See, it goes around. Coarctation. Aortic stenosis. But I can't get through there. Stenos. It's closing. And pulmonic stenosis. Real narrow. Look how narrow that is. Blood can't get through there. Decreased pulmonary blood flow defects. Tetralogy of Fallot and tricuspid atresia. These are incompatible with life, need to be fixed. That's all messed up. Tricuspid atresia. Mixed defects: transposition of the great vessels, total anomalous pulmonary venous connection, hypoplastic heart syndrome. That means right side or left side. It could be small. The heart can be small on one side, smaller than it's supposed to be, abnormally small, and the other side of the heart is normal size. See, that's supposed to be red up there. It's not supposed to be blue. Transposition.